Sorry.
All right, so you guys talk to each other and get it done.
Okay, go Tulu. Tell us what to do.
Okay, so, Abril, you two haven't really had that much. Yes. All right.
Electricist and when IS isn't working. Okay.
What type of patient interface would you use with that? What can you use?
Mouthpiece and the T-piece. Well, you don't need the T-piece, huh?
It
Just
would be
a
a
mouthpiece.
mouthpiece, trach adapter, or a cushioned mask.
Okay.
Okay.
And then
This part, I am not setting my coffee down.
you could do it.
Cushion mask. Expiratory. See this right here? Is the expiratory. You want to make sure that that is never pointing towards your face.
Okay.
That's why it swivels.
Oh.
Because anything that's coming out is from the patient's lungs. Oh, nasty stuff, right?
Yeah.
Medication here. Patient interface goes here. Oops, I'm sorry.
Just throwing it at you. You got it.
Save the coffee.
Okay. So you want them to be breathing into it. You explain to them, like, how would you explain to them, like, what they're going to be doing? Like, you would say, I want you to breathe as hard, like, as slow and deep as you can.
I want you to breathe comfortably.
Breathe comfortably, okay.
And this machine is going to help you take those deep breaths. So I want you to breathe in, and as you're breathing in, accept that volume of air, let it go in deep. And when you get to your max inhalation, I want you to softly exhale.
Okay.
If you've instructed the patient and you notice that it's taken the patient a while to turn that machine on, what's the issue with the machine?
It's too low.
Sensitivity. Okay? If the patient is trying to exhale and the machine won't turn off, what could be a problem? It's going to be a pressure issue because the pressure's still going, saying you haven't reached your pressure yet.
Okay.
Okay? It could be either or, but most of the time the sensitivity is for triggering the machine on.
Okay, so this is the sensitivity. This, we're looking at this to make sure it goes to -1 or 2, and it's when it does move, it's just gonna go slow and then back,
It's just
like a regular breath.
Just boom, then it's going to kick on.
And then if it bounces, then that means that it's too low, that you need to increase the pressure? Flow, okay.
Think of the flow is showing you how that breath is going in. Is it going to be a smooth breath or is it going to be a choppy breath?
Okay.
We want smooth.
And then, what was the other knob for?
You said flow rate start at 10?
No, that's pressure.
It's,
Pressure start at 10?
and then
And then
this is this side's the pressure? Okay.
What side?
This side. This is the sensitivity, that's the pressure, and then this is the flow? Okay.
Now, those numbers, do they represent exactly what you're giving to the patient?
No.
No.
So, do we turn it on? What else do you want us, we should be able to name what the different components are, and then also be able to instruct a patient?
I am more concerned about you knowing how to
Adjust
do
these?
this.
Okay.
Now, if you look onto this circuit, you have this squirrely stuff going on.
Uh-huh.
A couple of different tubes. Okay? One of these is going to the nebulizer. So the flow is helping nebulize this,
Oh, okay.
all right? This machine only nebulizes on inspiration. This other one right here works the exhalation valve. So when the patient exhales, okay, valve is going to kick in, it's going to stop the pressure.
Okay.
Okay, pressure should be complete, exhalation is occurring.
Okay.
If we set the pressure too high, you don't need to know this, this is just an FYI. If we set the pressure too high and the patient was really forcing against it, these things would pop off.
Oh, okay.
And it was a big old mess.
Because everything just leaks out.
Yep.
Oh, shoot.
Because this is just a small little rubber valve.
Uh-huh.
It's real thin. Yeah. And it was a beast trying to get it back because their fingernails could rip it. So we always had to wear gloves. I mean, yes, this was before gloves
Before we
were
had to wear gloves.
mandatory. Everybody know when gloves became mandatory? HIV.
Oh.
That's when they became mandatory. Just regular out, taking care of the patient, doing all that. All we did was wash our hands really well.
Oh, okay. How nice.
All right. So, remember, this is what?
Sensitivity.
Sensitivity. The lower the number on this dial, the more sensitive it is.
Okay.
All right? This is your manometer. This is negative. This is positive. Flow. How fast is that pressure being delivered? Pressure. How much pressure do we deliver to the patient? How much does it take? Can you hold that? I'm going to go get something. You guys play with it.
Okay, 10 to 15 to start at the sensitivity.
Okay.
20? Okay. Okay. So 10 to 15 for the sensitivity, 10 to 15 for the pressure, and then 20 for the flow. Okay.
To, count, exhalation. We go through all these attachments. However we did it, it goes on there somehow.
What did it, maybe because this thing was not on all the way then.
Anyway, the example was this bag had a smaller attachment and it would sit on here. So as the patient exhaled, we would count the number of breaths that it took to get this totally full. Okay? And then we would take whatever number, like this is 5 liters. Yeah, right. Okay. Probably take them a whole minute, right? So you would count their breaths, and you are going to divide the volume, divided by that respiratory rate.
And does that correspond with the graphs that we were
That's
doing?
going to help them. That's going to help you determine what their tidal volume is.
Okay.
Okay. And they have different types of bags. So, but thank goodness we don't have to use this anymore, right?
Yeah, it looks like it's going to fall apart.
Yeah. Okay, so if you had leaks, it would be at the wall, it would be here. Oh no. Oh no.
That's
Oh,
the
no.
leak?
Oh no. That's the leak.
I'm going to back up.
Yeah, because it could go shoot everywhere. It's still leaking. I can feel it. So, okay, so air comes in, usually attached to oxygen for the IPPB. Oxygen, the gas comes in, goes up here, through here, down into the machine.
Okay.
So, biggest leak spots are here and here.
Okay.
So there's a lot of factors we have to ask the patient to be able
And you can feel it, come over here and feel that, there's a leak.
Oh, yeah. And so when you turn it on, you're just tapping this red button right here?
Well,
This little
remember,
lever?
the patient triggers it on,
Oh, okay.
okay? This is, there are magnets in there, so it's dealing with the pressure, right? Patient breathes in, push in pressure, patient exhales, stops the valve, okay, pushes it back. This is for us, basically. Okay, you're having a hard time exhaling that out? Okay, let me pull this and let me readjust.
Oh, okay.
So when we turn it on, I see this one is like all the way over here. Do we put it at, what is it,
10 to 15.
It doesn't matter on this. It really doesn't.
Because you'll adjust the
Yeah, you're
sensitivity
gonna
after.
adjust it.
After they start breathing into it.
And now remember, since this machine's not working well, why?
It's old and it hasn't been calibrated.
It hasn't been calibrated in 22 years. It hasn't had any maintenance done in 22 years. And the thing, I plug it in and it still works relatively well.
Okay.
Okay, this I should go bury and wait another 10 years and it'll come up and it's gonna be like a new dinosaur. Also,
So when you're putting in something in the nebulization, what medication would we usually?
albuterol.
Albuterol, okay.
Albuterol, Atrovent, Mucomist, all that good stuff.
Okay. And then, so, we went over the indications, and then, we're gonna need to do the, contraindications.
What is a contraindication?
Not being able to follow directions. Unconscious.
Unconscious, but guess what? I've given this to plenty unconscious patients.
Really?
Via the air cushion mask
Oh, okay.
or via trach adapter, because they were trach.
Oh, okay.
You said esophagus.
Esophageal surgery, recent esophageal surgery, untreated pneumothorax, because they just make it bigger.
Okay.
What else?
The cranial.
Hemoptysis.
Hemoptysis, they're
Intracranial pressures.
Intracranial pressures, yeah. Okay. And then hazards and,
A hazard would be what? A pneumo.
okay. As you can
Make
make
hemoptysis.
too much, yeah, okay.
Headaches, hyperventilation, gastric distension.
There's a lot.
Yeah, there is. So for your skills test next week, did you guys know you have a skills test next week?
Next Friday, yeah.
Yeah, well, there's a syllabus, course outline. So for your skills test, it is going to be you telling me what each one of these do.
Okay.
And if I ask you a question like, the manometer needle is bouncing up and down when the patient takes a breath in, what should you do? Increase the flow.
Okay.
If it's bouncing up and down, that's turbulent. That means breath's gone. It's really not doing anything. So you want it laminar, you want it smooth with that pressure so it will fill up all areas of the lungs.
Okay.
Make sense?
Increase the pressure, yeah. If it's bouncing, you gotta increase the pressure, because it's what's getting, increase the flow. Increase the flow, yes.
So, to treat atelectasis. Okay, so, put this together. This is going to be a skills test. Okay, you have a small volume neb, and you have this. Put it together. That's what you do.
Okay. You have to be able to put it together.
Put it together. I want someone to put it together.
I'm not upright.
No.
No, it's up.
Wait,
no, it's
she was
right.
unable to do live. Somebody show her how to do
It's,
that.
yeah, upside down, yeah. It goes this way.
Like this?
Someone show her how to do this.
Wait.
Can somebody?
Tiffany?
I don't think I do it. So. You don't. Does anybody know how to do this?
Everyone should. I put it together for you last Friday.
I didn't see it.
Yeah, if you weren't here last Friday, that's okay. Nope.
Outside?
Nope.
Inside?
What did I say?
Yeah.
What are we doing here? Okay, patients breathing in.
Oh,
Remember?
now I
Are you
remember.
guys watching videos and looking at all that stuff?
I
What is
kinda.
Let's
Tried
put it
to.
back one more time.
Okay, okay, so what do you start? Patient's very first EPAP therapy. Very first. What are we going to run the EPAP at?
EPAP 5.
5. What are we running the nebulizer? 8. Okay, so. Here we go.
Okay, now try.
And on your mark, get set, go.
So-
You have 10 seconds.
So this
Hold on.
gets connected from here. What? Let me pause that.
Mouthpiece.
You can do nebulizer starts at 8.
Okay, EPAP at 5, nebulizer at 8.
Here, let's make it even more complicated.
They'll take out more pieces.
Oh, here we go. You want more pieces?
No more pieces.
That's so nice.
Okay.
Oh.
That over here. Okay, now put that on. Yeah. The other one.
So that
Now
was
the
good.
mouthpiece, the other side.
Remember that
Other one,
this
yeah.
piece, you see how it's cut out?
Uh-huh.
Just know that nothing attaches to that.
Okay. And then the oxygen. That one goes to that one. And then that one goes to the top. Right there. Oh.
Oh.
But it stays. It's supposed to stay.
I know, right? It came off right.
Okay, so you're gonna have it separated and we're gonna have to put it together. Okay.
It keeps falling off.
Well, show it who's boss.
What happens if we break it?
Because this is going to happen out in clinic, right? And
Yeah.
you want to be able to put
To
these
do it.
things together.
Okay.
Remember, if anything can go wrong, CPAP only with no small volume nebulizer, this is what it's going to look like.
Okay.
This is how it comes in the package. The dial on top, right? So, you look at the arrow. Where should you start for the patient's very first therapy?
5.
5 on the pressure, 8 on the liter flow. Do you touch the liter flow on it? According to the manufacturer, you do not have to. You only need to adjust this. So the higher the number, okay, the more resistance there is, which means the greater the back pressure, which means more alveoli are opening. Did I say yes?
Yes.
So your EPAP and your APAP, we're still working off of that negative pressure. Patients are taking the deep breath in, but when they exhale, what is occurring? They are breathing against a resistance. And that resistance is saying, no, we're going to keep that in your airways. You can't exhale all of that. So it's supposed to comfortably and easily open up those alveoli.
So your job is to explain to them what's going on.
So,
You have this little
CPAP.
thing here where you can actually like say, okay, well, your normal cycle.
What is a CPAP?
Anything less than 50%.
Have you guys even seen one?
Is very bad. So you're 50%.
In clinicals.
The one in the back.
So if you can't even get
The CPAP. Let me show you. I'm going to go right here.
measure this on a regular basis, you understand. We always say like,
is a simple CPAP machine. It only does CPAP.
No. Oh, you would instruct them how to
So, on-off button has to plug in, it's electric, this is the humidifier, this is the tubing for the patient, okay. Physician would set it, or straight therapist would set it, this dial is for the humidity, okay. The higher the number, the more humid it is. So, mask treatment. They'd have to wear this 24/7 for about 48 hours to show any improvement, right?
mouthpiece, right?
And,
48 hours?
yeah,
Okay.
because I think they said in your textbook that if it's less than 24 hours and they take the mask off, within 10 minutes the alveoli close. It was something like that.
Yeah.
So CPAP. One pressure means the patient's breathing in that one pressure and breathing out against that one pressure. So if they're set on 7 centimeters of water pressure, that 7 is in the airway and supposedly in the alveoli all the time. Inspiration, expiration. Because it says continuous positive airway pressure. Okay? Isn't it so cute?
How does that help a patient if it's the same thing in and out? How would that help a patient if the pressure is in and out the same number? Wouldn't it be more pressure in to expand the lungs and less pressure out?
That's why we've gone to the BiPAP. So do you see why we really don't use that? But we really don't want to use a BiPAP for just lung expansion therapy. That's why coaching and literally babysitting the patient, making sure they're doing what they're supposed to do with the IS, with the easy PAP for the APAP, getting that patient up and getting them moving. Because if they develop atelectasis, they'll most likely develop another gun. And now they're going to go into respiratory distress, eventually respiratory failure, now we're on the vent. We don't want to do any of that. Inspiratory is always higher than expiratory.
BiPAP is 2 pressures. Okay.
Inspiratory is always higher than expiratory. And we have a whole chapter on the BiPAP.
Are we gonna need for our clinic, the skills test, are we gonna need to know the buttons on that or?
No,
No,
it's
okay.
going to be, this is one pressure.
Okay.
Patient must wear it 24/7. Not really used for atelectasis,
Okay.
but it's still in the chapter as lung expansion therapy, which is hokey. So according to your textbook, what is the pressure range used? 5 to 20 centimeters of water pressure for CPAP. 5 to 20.
Yeah. That's really, if you think about it, it's measuring how much volume